Cardiovascular Medications and Alzheimer's Disease Risk Reduction by Dr. Sina Rafatous. For decades, medicine treated cardiovascular disease and Alzheimer's as isolated conditions in separate systems. The clinical data now points to a different reality. They share an intricate pathophysiological network known as the heart-brain axis. This physiological overlap creates a clinical paradox. We now have specific classes of cardiovascular medications that significantly reduce the incidence of dementia in at-risk populations. Yet, despite this success in prevention, there is not a single cardiovascular medication FDA approved to treat established Alzheimer's disease. Our objective today is to map the specific cardiovascular regimens that confirm measurable neuroprotection based on the latest trial data. We will also look at the reverse, deconstructing routine cardiac medications that actively induce reversible iatrogenic cognitive failure in older adults. Protecting cognition requires managing the vascular environment, a challenge that begins decades before the first sign of memory loss. Systemic markers and hypertension drive atherosclerosis, physically degrading the cerebral arteries. As these walls narrow, cerebral hypoperfusion starves the brain of blood flow. This damage disrupts the blood-brain barrier, allowing neurotoxic amyloid beta and tau to deposit directly into vascular walls. Patients with severe carotid atherosclerosis show a threefold increase in Alzheimer's prevalence. That risk amplification is particularly aggressive in patients who carry the ApoE4 genetic allele. Because the accumulation of vascular amyloid and endothelial damage takes years to compound, the preclinical phase of Alzheimer's functions largely as a vascular disease. To counter this vascular degradation, intensive blood pressure control is our first line of cognitive defense. Data from the SPRINT trial and AHA guidelines shows targeting a systolic blood pressure below 120 reduces mild cognitive impairment risk by 19%. But specific agents matter. Comparing angiotensin receptor blockers against ACE inhibitors, ARBs demonstrate a measurable neuroprotective advantage. Epidemiological data confirms ARB therapy yields a 22% reduction in any dementia and a 27% reduction in Alzheimer's disease. The effect size grows in vulnerable populations. In patients who already have both hypertension and mild cognitive impairment, ARBs are associated with a 55% lower risk of progressing to full dementia compared to ACE inhibitors. The specific ARBs demonstrating the strongest neuroprotective associations are olmesartan, candesartan, and telmisartan. Furthermore, ARBs provide a targeted benefit to ApoE4 carriers, reducing hazard ratios down to 0.32 in this high-risk genetic group. ARBs deliver a class-level neuroprotective superiority. For cognitive preservation, they are the preferred antihypertensive intervention. Lipid management reveals similar benefits. A meta-analysis of 42 cohort studies, spanning over 6 million patients, found statin use is associated with a 29% reduction in Alzheimer's risk. Despite public concern about statin-induced memory loss, multiple large randomized trials and the AHA confirm statins do not cause cognitive impairment. The effects reported in post-marketing reviews are rare and reversible upon discontinuation. In patients with atrial fibrillation, resolving erratic rhythm and clotting risks preserves cognition. Oral anticoagulants reduce dementia risk by 12 to 60% across population studies, with direct oral anticoagulants generally outperforming traditional warfarin. For heart failure, there were initial theoretical fears that Entresto, a combination of sacubitril and valsartan, might increase brain amyloid because it inhibits the enzyme neprilysin. The clinical data has disproved this. Results from the Paragon-HF substudy show Entresto is associated with a 15% reduction in all-cause dementia risk. Looking at this timeline of metabolic interventions, GLP-1 receptor agonists demonstrate an approximate 45% reduction in dementia risk during the midlife prevention phase. But watch the established disease phase. The Phase 3 EVOKE trials tested oral semaglutide in early symptomatic Alzheimer's. The efficacy line flatlines. There was no clinical efficacy in slowing progression. The EVOKE failure proves the rule of the prevention paradox. Achieving risk reduction in midlife does not equip us with a viable treatment once the disease is established. While some cardiac medications protect the brain, Others actively impair it. Between 2 and 12% of patients presenting with suspected dementia are experiencing drug-induced cognitive decline. Here is the blood-brain barrier. Fat-soluble lipophilic beta blockers, specifically propranolol and metoprolol, easily cross this barrier. They enter the brain parenchyma and disrupt neural synapses, causing confusion and impaired memory. Contrast this with water-soluble hydrophilic alternatives like atenolol. These molecules bounce off the barrier, leaving the central nervous system undisturbed. Beta blockers aren't the only offenders. Antiarrhythmics like amiodarone have high CNS penetration, and digoxin alters amino acid transport, triggering delirium even when prescribed at standard therapeutic doses. Other risky medications flagged by the Beers criteria include central alpha agonists like clonidine, immediate-release calcium channel blockers like nifedipine, and peripheral alpha-1 blockers like prazosin. We also have to account for anticholinergic burden. When patients are co-prescribed non-cardiac medications like antihistamines or bladder antispasmodics, they compound the toxicity of cardiac drugs, increasing the risk of cognitive adverse events. Assuming cognitive decline in an older cardiac patient is strictly a result of neurodegeneration is a dangerous oversight. Frequently, the daily regimen itself is the culprit. To manage these variables, cognitive monitoring must be integrated directly into routine cardiovascular care. This is the Deprescribing framework. It begins with required screening touchpoints. Clinicians must establish a cognitive baseline at the first encounter, monitor it longitudinally during outpatient care, and screen prior to any hospital discharge. These touchpoints rely on specific, validated tools, the MoCA, the MiniCog, or the informant-based AD8 questionnaire. This enables the golden rule of geriatric cardiology. Any new cognitive symptom in an older cardiac patient must be evaluated as an adverse drug reaction until proven otherwise. When symptoms appear, a systematic medication review is required, cross-referencing the patient's regimen against the AGS Beers criteria and the stop-start guidelines. Practitioners must also calculate the anticholinergic cognitive burden, or ACB scale. A cumulative score of 3 or higher indicates a clinically relevant risk and requires clinical intervention. Actionable deprescribing follows. This means transitioning patients from lipophilic to hydrophilic beta blockers and swapping central alpha agonists for neuroprotective ARBs. The standard for this is the age-friendly 4Ms framework, prioritizing 4 integrated pillars: what matters, medication, mentation, and mobility. The data suggests that aggressive, optimized midlife cardiovascular management is currently one of the most evidence-based strategies for reducing Alzheimer's risk. To ensure we protect the aging brain, that midlife vascular optimization must always be paired with structured geriatric deprescribing.